All right, so we'll go ahead and get started. So, hi everyone. My name is Anushree Kumar. I am an internal medicine physician and menopause and midlife specialist in the Sugarland area. And I have here a very well-known and experienced psychiatrist, Dr. Onyi Okeke. And we're going to talk today a little bit about perimenopause and the menopause transition and mental health. Welcome, Dr. Okeke.
Thank you.
Do you want to tell us a little bit about your background and what you do and specialize in?
Yeah, thank you. And thank you so much for having me. I'm really excited to be here. So my name is Dr. Onyi Okeke. I'm a psychiatrist. I say I take care of women, moms, children, and teens, but I can take care of anyone under the age of 64 at our practice Muna Psychiatry Group. We're in person in Katy and virtual across Texas, and we take most major insurance plans. And before this, I was doing child psychiatry in Connecticut, where I went to child and adolescent psychiatry fellowship, did fellowship in consulting as well. I've trained a lot and worked with a lot of people with different medical and mental health challenges. And so I was really excited to start our own practice, which we just launched in January, but it's been growing very fast. And we've gotten really great response from the community because the need is there for accessible, high quality mental health care. So we're just really excited to continue to connect and get the word out and see how we could be helpful.
Yeah, that's wonderful. And me and you and I recently connected, and we both share a passion for women's health
Sure.
and especially midlife care. And I think through our individual practices, we have both seen how so many women they come in midlife, and all of a sudden, maybe it's all of a sudden or over time, mental health becomes such a big concern, right? And
Sure.
sometimes it's the first time in their life,
Mhm.
and sometimes it's an exacerbation of symptoms that they have felt and
Yeah.
experienced before.
Mhm.
So, just as an intro, like I think when most women think about perimenopause, they're usually thinking, oh, hot flashes,
Yeah.
irregular periods, sleep changes. But I think a lot of women don't realize, or what catches them sort of off guard is that kind of mental and emotional transition.
For sure.
And what's so interesting about midlife. And I think I always tell patients that today's generation is living midlife in a way that is almost so unique to
Mm.
previous generations because when our parents maybe were in their late 40s, early 50s, they didn't have children at home. Like today's 40, 50-year-old women have young children, they have demanding careers, they have, aging parents, and then social media and all of the influence of that. And so then when you're in that age and you think you're depressed and anxious, you don't know, is it something hormonal? Is it medical genetic? Is it just all the stress and burnout?
For sure.
And I think that's where like providers like you and I really come in, right? And
Yeah.
we want to we work with these patients, and we want to help them understand um, what's actually going on and what they can do to help
For sure.
themselves.
Yeah. 100%.
So in that light, so when women in their 40s, early 50s, they come to you for an evaluation, what's like some of the most common ways that they describe like what they're experiencing?
Yeah. So I get this a lot, like women coming in their late 40s or 40s, 50s, and maybe never seen a psychiatrist before. Really often always high achieving, always did well, always pushed through, always like worked really hard, did what they had to do. And now it's like they hit a wall, they don't feel like themselves. It's just something's off. They're not feeling themselves, or they're more irritable, more cranky, their fuse is shorter. And maybe they don't feel like depressed, how how we think of depression, or they don't feel anxious in the way we think of anxiety, and they're coming to me not quite sure what is going on, but open to talking about it. And it's very infrequent that I see someone coming in like saying like, I feel so sad and so depressed. It's these things that are a little bit more subtle that we can chalk up to stress, which it could be stress. It could be all the above that you had said. and it's not immediately triggering us to think like maybe we need to see somebody to look at our mental health with us.
Yeah, no, I absolutely agree. And I would say almost all the patients that I see, they often come in and it's very similar to what you're describing. They're suddenly like, I don't feel like myself, right? This is a very common phrase now in the perimenopause world, but it's so true um, that things are changing. They don't know why. And sometimes it happens so insidiously that you don't even realize it could be
Yeah.
related to hormonal transitions. And what I think is interesting, that you're completely right, that symptoms are not always your classic anxiety and depressive symptoms. In fact, surveys have been done on women in this transition, and it shows that the most bothersome symptoms for women is actually irritability. And I mean, I see this in my clinic all the time, like rage. I get so many women who describe rage, like, I can't tolerate my husband, I can't tolerate my kids or my friends. And then this feeling of feeling overwhelmed, right? And it really takes a little bit of an educated deep dive to connect irritability and feeling overwhelmed to maybe a mood disorder or a mental health concern that we can actually treat.
For sure. Yeah. I was gonna Sorry, I was just going to add that we have a lot of reasons to feel overwhelmed and frustrated and irritable. And so we can kind of say it's related to those things, our kids, our partners, the bills, our demanding jobs. There's a lot of things to juggle, and it can take a toll for sure. And so it does take a toll. Yeah.
Yeah. And perimenopause is not just this simple, straightforward transition where you go from cycling to not cycling, right? Menopause is when you haven't had a period for 12 months, but perimenopause is this transition that spans 5 to 10 years. And it's not just this smooth decline in hormone levels. It's actually the ovaries kind of go crazy during this time. And estrogen production becomes incredibly volatile, and it can fluctuate daily or several times within a day. And, because our brain has so many estrogen receptors, when we have this wildly fluctuating roller coaster of estrogen levels, then our hormones our mood, ends up on a roller coaster as well.
Sure. Yeah.
Right? And yes, you're totally right. This happens at the same time as caregiving, career pressures, kids, parents, all of that. So why would a woman who's really never thought of herself, as an anxious person suddenly experience some of these like panic symptoms or have this lower tolerance for stress?
Yeah, that's a really great question. And it's really individualized. And I think the first step is saying, let me just talk to someone and see if I could get some help in this area. We don't have to wait until we're at our wits' end to be able to get some sort of support. And so I would say that long-term weight of all the things that we're carrying as women, trying to navigate when our hormones fluctuate, even before perimenopause, even with our period, it does affect our mood and how we relate in the world. And we want to be our best self for our partners. We want to be our best self for our kids and at work. And over time, that does take a toll on us, understandably so, because there's a lot to navigate and to be on all the time. It can be really exhausting. And so that's where I would say it starts. There's the hormonal fluctuation. So we are experiencing almost every month. And then as we're going through perimenopause, it gets even more heightened. And then, as we go through that process, it gets even more heightened. And we don't learn a lot about how our hormones affect our emotions as well. And so it can be really tricky to figure that out and understand, even, people trying to get their hormones tested, as I'm sure Dr. Kumar, and like everything looks normal. And so, but there's so many layers to it.
Yeah. And I think what adds to the confusion of perimenopause is that studies have shown that irritability and mood changes actually precede the classic
For
symptoms
sure.
like
Mhm.
hot flashes and menstrual irregularities and the insomnia. And so when a woman is having relatively normal cycles and then she is feeling all these symptoms, then she's wondering, what's wrong with me? Which
Yeah,
is like really sad to hear as a physician, as a provider, as a clinician, right? Because the worst thing is when patients think it's their fault, but there's something organic that we can do something about.
yes,
So I think it's really important for patients to know that in this age group, regular periods do not automatically rule out perimenopause.
exactly. Hmm.
So tell me, so if you have a woman that comes to you and she's experiencing these changes, how do you go about evaluating them? Like, how do you decide like this is perimenopausal, or is this truly major depressive disorder, or is this generalized anxiety disorder?
Hmm.
Do you have sort of a framework or something that you can kind of tell us about?
Yeah, so the secret sauce really is in the history, and it's understanding that person's life up until they got to this point. So I'm also a child psychiatrist, so I look at everything from a developmental lens, and I'm looking at like what life was like before, kids and partner, what life was like, early on and maybe now, and plans for the future. And so thinking about their life when they were younger, this woman, when she was in college or early on in her career, did she have challenges with anxiety and depression? Or is this completely new? Like, I never had
Mhm.
these types of challenges. Yeah, I'd go through hard things, I'd be sad for a couple days and then I would usually bounce back. But now I feel like I'm not myself, like you said, Dr. Kumar. Like, it's
Mhm.
not as easy to bounce back from difficulty, or I don't even know why I feel so cranky.
Yeah.
And it's completely new. And then that makes me think less about it as a primary anxiety depression. It doesn't change how I treat it from the mental health standpoint, but it would
Mhm.
also very much encourage me to see somebody like you, Dr. Kumar, to see if they are a good candidate for hormone
Mhm.
therapy, for instance.
Yeah. Yeah, and I would just add to that, when we look at mood changes in the perimenopause phase, it's also so important to know what happened to what did the patient go through during any pregnancies that they had and the postpartum period.
Yes,
Because some people have a genetic or innate sensitivity to hormone fluctuations.
sure.
And a
Yeah.
lot of times you'll see that during their life when they had hormone changes, such as pregnancy, postpartum. They were very sensitive to that. And some people got treated for it and some people didn't. So I agree with you. The secret sauce is in the history, and we have to dig deep and say, really, like, I know you didn't take,
Yeah.
antidepressants postpartum,
Yeah.
but how really, really, truly, how was it for you?
Yes. Yeah.
Um,
Yeah. And I would add really quick that I think even understanding what postpartum depression and anxiety is
yeah.
also very tricky because it looks so different in everybody. And then it can be full of a time full of shame. Like, I should be happy. I should be excited. I have this new baby. And it's not sometimes not even until hindsight, thinking back, like when we're asking about the history, that actually, yeah, I felt disconnected from my baby, or I was having really intrusive, really
Yeah.
scary thoughts, during that time. And that's
Yeah.
something that we don't always have time to share during our OB appointments, or realize that it's something that happens to a lot of women postpartum. So definitely, I think we as a whole don't realize how much our hormones affect us at every stage, even
Mhm.
just during our periods, or, pregnancy, pre-pregnancy,
Yeah.
postpartum, and ongoing. It's something that we could use a lot of education about, and helping us advocate for ourselves when we go to see doctors about how our hormones are affecting our mood and anxiety.
Yeah, absolutely. And, I see a lot of high functioning women, right? And I think high functioning women are your classic minimizers of their own symptoms.
Mhm.
Um, and it's just so important for them to really kind of come out and really be introspective about the struggles they've gone through and how they've handled it.
Yeah.
And talking about like what does burnout feel like, and what is, what can you do? How do we manage our mental health?
Mhm.
So one thing I wanted to bring up with you is ADHD. So we know perimenopause causes brain fog, insomnia, hot flashes, panic and
Mhm.
irritability. And so many women, they wonder, do I have ADHD? So tell us, like, how would you answer that question? Or
Yeah,
how can we kind of evaluate that?
for sure. So this is like it's not just a hot topic right now, but it's something that is really opening up the eyes of psychiatrists in general, like even bigger than perimenopause. And so we know the literature is showing that ever since COVID, more women are getting diagnosed with ADHD. And
Mhm,
simply because, not simply, but as younger children, women, girls don't really present maybe hyperactive, maybe more inattentive, quiet, will do the things that need to get done and it'll get missed. And it can get missed for many years.
mhm,
The important kind of distinction between like a new ADHD and untreated ADHD that's gone for years, again, goes back to the history. Is it a lifelong challenge somebody has had that they've pushed through and been excellent because they know that they struggle, and so they push and
mhm,
push and push, and then get to a point of these perimenopausal years, which their period still could be pretty regular, but my thinking is not clear. I feel like I have brain fog. I don't know what's going on. And so this shows a long history of ADHD symptoms that have been what we'd say compensated for. You figure out ways to be less forgetful, and you figure out ways to manage the high energy. Maybe you did sports or something like that.
mhm,
And so there's that phenomenon that's been going on. Like we're more educated about ADHD, and people who were not previously treated were understanding more. And then perimenopause, these symptoms come out more. And then people getting treated in their 40s, 50s, something that they've been dealing with their whole life.
mhm.
Versus somebody who usually has been on top of things, usually is pretty organized, and usually has a pretty good memory. And now thinking is just not as clear,
Yeah.
being way more forgetful. That would lean more towards perimenopause related symptoms than a new ADHD. And the literature also shows that the ADHD treatment for those symptoms does not help as much as if that person is a good candidate for hormone replacement therapy.
100%. And I see this all the time in my clinic where sometimes we don't know what's the root cause of a symptom. I mean, I see patients for fatigue, insomnia, of course, mental health like anxiety, depression.
Mhm.
And there's so many different possible causes.
Yes.
And there's really oftentimes no one lab value. And getting a history sometimes it's hard. It's hard to recall exactly what was happening and the intensity of it and all of that. And sometimes the best way to diagnose something is to treat it and then see how it works,
Mhm. Yeah.
Um, and I think with hormone therapy, that's like a common thing because it is hard to know. And then we have some patients who take some hormones and all of a sudden they're just living their best life. And
Mhm.
lots of patients start hormone therapy and they feel a little improved, but yes, you're right, like that anxiety or the sleeplessness or the depressive symptoms are still there.
Mhm.
And for me in my clinic, that's especially when I'm like, okay, we need to add on
For
um,
sure. Mhm.
some kind of antidepressant or some kind of anti-anxiety regimen, which
Mhm.
will help,
Mhm.
Um, yeah. So, if a patient thinks that they may have had ADHD their whole life and now it's gotten worse, or now they're kind of just not able to handle it and they've managed it themselves,
Mhm.
what's their process for actually getting diagnosed? Is
Yeah.
it just history based?
Yes. So it depends on the psychiatrist that you see. So some psychiatrists like me, I see children. So ADHD is my bread and butter. I'm very comfortable taking a history and getting a good idea if this person has this lifelong diag- like um, diagnosis of ADHD or if it's something else. If it's a little bit
Mhm.
tricky, then there's always neuropsychological testing, and there are groups that I work with that provide that testing that gives an objective measure of whether somebody has ADHD or not, or if there are other kind of mental health challenges that are contributing to what is being seen now. So that's usually, I tell people, see a psychiatrist that specializes in ADHD or an adult psychiatrist that also sees children. That'd be a really
Mhm.
great way to get a strong diagnosis. And if they're not sure, then they might send you for objective testing as well to help make sure that it's being clear and that they're confident in the diagnosis.
And what are our treatment options at ADHD? I know it's complex and individualized, but what are women looking at if they do get a diagnosis of
Yeah, for
ADHD?
sure. So what I mentioned to the women that I work with and the children I work with as well is that ADHD treatment is in like two categories: stimulant medications and non-stimulant medications. And so the non-stimulant medications are medicines you might have heard of, like Strattera or atomoxetine, also Wellbutrin, bupropion. Those can be really great if somebody
Mhm.
has anxiety, depression, and some focus problem,
Mhm.
versus the stimulant medications, which is good for very clear cut bread and butter ADHD treatment. And those are medications like Vyvanse, also lisdexamfetamine, that's the other name for it, or like Adderall and methylphenidate. And those are all in the stimulant categories. And so it really depends on the conversation with the doctor, what medicines you feel comfortable with, and which medicines they feel like would be most helpful and effective for you at that current time.
Yeah, yeah. And how does therapy play a role
For
in
sure.
ADHD?
Yeah. So I would say, especially, for women and I mean, I would say for everybody, but especially the women that we work with, going, a lot of them really high powered, working really hard, trying to be the best for their family and their kids. Therapy is a great resource to help us to talk through things that we might not have the ability to talk to anybody else about, or just thinking about patterns, struggles that we have. And specifically in ADHD, therapy can serve two different purposes. And you can have, I mean, there are a lot of different purposes, but the two big high yield are the regular talk therapy and kind of working through maybe some challenges that we have, and also
Mhm.
executive function coaching, which is basically working through help with strategies, which a lot of people
Mhm.
could probably benefit from. I know I could, in terms of
I could too.
organization and
Mhm.
like ways to organize yourself, creating systems in your home and family just to make things a little bit less stressful.
Yeah.
Therapy is really great for everybody, but it can help with a lot of different types of struggles, whether it's like talking through things, which obviously doesn't make the struggle go away, but it does really help to get it out and
Mhm.
out of your body to help like reduce that stress and tension.
Mhm.
And then versus like actionable steps one can take to kind of organize themselves and their life to also help
Yeah.
reduce that anxiety and stress.
Yeah, and I think it's a very nuanced discussion with every woman, right? Also, what I've seen, I'm sure you agree, and is that sometimes like anxiety and depression feels like ADHD
Oh
as
yeah,
well,
for
right?
sure.
I get so many women who tell me they have ADHD, and
Mhm.
really it's more it's more flavors of anxiety or
Sure.
depressive symptoms.
Yeah.
Um,
Yeah.
yeah, because that those transitions, even hormonal transitions, they reduce attentiveness
Of,
and
of
they
course.
can increase forgetfulness and those sort of classic symptoms that we think of as
Exactly.
ADHD.
Mhm.
Um, yeah, so mental health in midlife is complex. It's nuanced, I think, probably as nuanced as it can get and
Mhm.
as complex as it can get in an adult in a person's career, in a person's life, right?
Yeah.
um and one of the things I want to talk about is that there's really no single treatment that's right for every woman,
Mhm.
right?
Yeah.
And our goal in this discussion is, like, our goal in caring for a patient, my goal in caring for a patient is really to um, tease apart every element that can be contributing to
Yeah.
life factors and not to reduce every symptom to hormones,
Yeah.
or to assume that every woman needs the same solution. Because
Yeah.
I feel in my practice, I have never been able to do the exact same thing for
Forever.
two women and get the same result.
Yes.
You know, I wish I could standardize the protocol,
Yes.
but I'm not
Yeah.
able to.
Mhm.
So let's just talk about like woman, she's changing, she's feeling anxious, overwhelmed.
Mhm.
Where do we begin?
Yeah.
So when I see a patient, of course I'm an internist, so we go through a lot of different categories of care, and then when it comes to the mental health part of it, it's a more limited discussion than you would have,
Mhm.
because we have many things to go through.
Yeah.
But I think the most important, I always tell women, the best way you can advocate for yourself in an appointment is to have as much data as you can,
Mhm.
right?
Of course.
Journal your symptoms and
Mhm.
think about your history. Think about your personal history.
Mhm.
Like we just touched earlier.
Sure.
What was your childhood like? What was your adolescence like?
Mhm.
When you had children, the pregnancy, the peripartum, postpartum phases, what were they like? And
Mhm.
what are you feeling and experiencing now with
Yeah.
menopause? And especially with perimenopause, I always encourage women to journal their symptoms on a daily or weekly basis, because as we can see that mood symptoms can get worse during the premenstrual time, right? Or some people have irritability, rage, anxiety throughout the month. And some
Yes.
people can have very focused symptoms.
Mhm.
So I always tell patients, number one thing is you can journal your personal history. Number two, get a family history.
Mhm.
I find the family history is incredibly useful,
Yes.
not just to know the age not just to know, are there mental health disorders in the family, because I think there's a strong genetic or epigenetic
Mhm.
um, uh, connection, but also, when did your mom go through menopause? When did your mom experience menopause, right?
Yes. Mhm.
Do you have any sisters or aunts, and when did they experience menopause? And all of these add data points to the clinical picture. Not any one point is not going to tell us everything we need to know. And if there's something you don't tell us, it's not going to be a huge
Yeah.
loss. But the more data we have, the better a patient can advocate for what they're feeling
For
and
sure.
what they're looking for.
Mhm.
I think it's really important to go through, any medications, right? We have lots of medications that can contribute um, to feelings of anxiety, feelings of, mental health, unwellness.
Mhm.
And also, it's so important that besides perimenopause, think about other medical conditions that contribute. This includes, I see iron deficiency anemia all the time in my clinic, or iron deficiency with or without anemia is what I should say.
Mhm.
And thyroid disease is a very common one as well that we see in midlife women.
Mhm.
Sleep disorders,
Yes.
vitamin D deficiency, sometimes just poor nutritional intake for whatever reason, insulin resistance.
Mhm.
All of these conditions, believe it or not, have symptoms that overlap with
Yeah.
perimenopause
Yeah.
and depression and anxiety.
Sure.
Right?
Yes. Yeah, for
Yeah.
sure. I was gonna add, like, I had a woman in perimenopausal age coming to me with brain fog, not feeling herself,
Mm-hmm.
and then some depression. She probably had a long-term history of ADHD as well, based on the history, but I sent her back to her primary care because I think based on the history and her family history, I think she needed to get her thyroid rechecked. It was a little bit high, but I was like, based on the history, it could be a thyroid disorder. And then also sleep apnea is another thing that we ended up talking about, not treating for
Mm-hmm.
not I think we ended up treating her depression, which was pretty profound, but that it's only going to get so much better if the thyroid is not addressed and if sleep apnea is not addressed.
Mm-hmm.
Everybody,
Absolutely.
if you're not sleeping well, you're not going to feel well. So
Yeah.
it's like a pie, and each thing is a little piece, and the medicine is this much, but there's so many other pieces that make us feel well.
And yep, that is the theme of the discussion for today and in my practice and in my life. I feel like this is something I talk about all day, every day with every patient. Like we
Mhm.
have to look at every factor that's
Yeah.
contributing, and every factor that you can target and improve, it's only going to help your symptoms.
Mhm.
And yeah, so when it comes to, we talked about therapy and the importance of therapy, and but sometimes what I find is that several women are so frustrated with their symptoms, or they're at such a low point
Mhm.
that they don't really have like the patience and the time to really go through the therapy process. Or maybe they're willing to start therapy, but
Yeah,
we need to look into medications as well.
for sure.
Um, and I would like to know if you agree, but what I always find is that sometimes symptoms can be so distressing that it's hard for a patient to actually participate in therapy,
That's true. Yeah.
and sometimes they need the medication in order to participate in therapy, and then later we can take the medication
Sure.
off.
Yeah.
Is that something you see with your clients and patients as well?
Of course. Yeah. So what I say to patients is when we're treating a mental health issue, I would very much encourage them to think about it as a physical health issue, like high blood pressure. Like you wouldn't say like, "Oh, I need to just get it together and get my blood pressure down." Well, and I mean, in some instances, we do some things to try to get our blood pressure down, but there's some things that we can't do. And so it's the same way with mental health. There is still some stigma. I think that a lot of it is getting better of
Yeah.
not thinking of it as a personal failure. I think women, we have this unique sense to feel like we should be able to handle it all at all
Mhm.
times, but that there's no award for suffering. And so what I say to everybody when they come to see me and my private practice or see any of the physicians that I work with is that we're just having a conversation and I want to hear from you, hear what's weighing heavy on you, where you think you need support, and I'd offer some recommendations. There's no pressure to proceed in anything.
Yeah.
What I feel like would be helpful. I'm here to answer your questions. And really it's a collaboration because if the person I'm talking to doesn't feel comfortable with what it is that I'm talking about, it's not helpful for either of us. And so I want to make sure the person understands why, this medicine or this therapy is being recommended and the thought
Mhm.
process behind that, and trying to find some therapy. I have a pretty good network of therapists I work with, thinking of a group or a particular therapist that would be a good fit, and just trying to help connect people with something that I feel like could be of help to them. And the same thing with
Yeah.
medicine is if I give a recommendation, if you're willing to try it, we'll follow up soon. If you hate it, stop it. We'll check it again. And I think really working with women, working with moms is really helping them feel like it is a partnership, because
Mhm.
we're doing it on our own for so long, and we might feel like we go to doctors and we talk and feel like we're not heard. And so I want you to feel heard, but also want you to hear where I think things could be better. And then we work together to
Mhm.
figure out where to go. And
Yeah.
so I feel like that has been very well received and very rewarding for me to help women who felt like they have not been heard for so long and don't know what's going on. And yes, this is just a piece of it, but we can put little pieces together to make things
Mhm.
better.
Yeah, and I think this is how medicine is changing in recent years, right?
Yeah.
Um, 15, 20 years ago, at the time that we trained, it was a very hierarchical relationship.
Yeah.
And a patient says that something's bothering them, and the doctor tells them what to do and sends them home.
Yeah.
Now it is such a conversation, it is such a partnership. And when I see patients many times, I tell them, like, these are the possible treatment options. What
Exactly.
would you like to do? And how
Exactly.
would you like to proceed? What are your preferences? And I'm not doing that because I don't have an opinion or I don't have guidance, but I want to know what are their thoughts coming into it.
Yeah.
And then, of course, I provide them guidance that, yes,
Yeah.
I think this is reasonable, or if it were me, this is what I would do. But
Exactly.
ultimately, it is so empowering. And I think women and men want to feel empowered
Yeah.
in their decision making process, and they want to feel educated.
For sure.
And I think you and I, the kind of time that we spend with patients, we're so fortunate
Yeah.
because we are able to talk about the pros and cons of different therapies. When it comes to mental health, I'm sure you see that one of the most frustrating aspects for patients can sometimes be the fact that antidepressants take a long time to work.
Yeah.
And sometimes you have to change them a few times or change the regimen a few times. So it can take a few months
Yeah.
or a year. It can take quite a bit of time and a trial and error to really find what works for a patient.
Yeah. Hopefully it doesn't
Yeah.
take that long.
Hopefully not that long. I would
Yeah.
say usually not, but I certainly see that patients sometimes need to try anywhere from 1 to 3 antidepressants to really feel good. And
Yeah.
it just is what it is. Of course, we have some that are more commonly well tolerated and some that are less, but
Yeah. Yeah. And I would also say that's also where the therapy conversation comes in. So like I was talking to a woman earlier today who we switched. She came to me on another medicine and I was like, I don't really like this one. We tried a different antidepressant and it's like a little bit helpful for some symptoms, but not all symptoms. And we had talked about therapy before, but it was something, she hadn't really had the opportunity to follow through on, even though I try to help therapy group reach out to her. But I gave them the number. I said, I think it would be really helpful to connect with therapy. We adjusted the dose, but it's both. Like the medicine only does so much. And I think if we think about medicine going to be like fixing all the issues, we're going to have a problem and be really disappointed because it's only one piece of the tool. There are other tools like, moving your body, nourishing your body, and therapy as well. So, and that's kind of the soapbox moment I have. It's like, maybe we should try therapy again because this is not exactly working in the way that you want. So, yeah. And that helps my job be easier and her job to be easier because then we're not wasting each other's time. This is not working as fast or as much. Let's try something else and, walk through this together.
Yeah, absolutely. So I think this has been a really, really good, fruitful discussion. In conclusion, I would just like to ask you, what's one sort of message or point that you wish, every woman in her 40s kind of knew about mental health?
For sure. Yeah, I would say and encourage every woman that you don't have to wait to be at your breaking point to get help. It's just a conversation. And that's where I start. Get your questions answered. If there are things that I don't know, I will let you know. I will share. I would, pass you along to somebody who might know more than I do, like Dr. Kumar, for instance, if it's something related to hormones. But we don't have to wait till we're at our wits' end to get some sort of support. I think the biggest step is connecting to a physician that you feel connected to, that hears you, and you can work through this together. And so that would be my encouragement. I see so many women who are just like, I've been struggling for so long and I just wish I could get there sooner. And that's part of why we do talks like this. We want people to hear about the work that we do. We want to help people. And so that's what we're here for.
Yeah, I love that. It's so true. And I think, one message from my end is so many women come in and thinking, I'm getting old. This is normal. I'm getting old. It's normal to be tired. It's normal to, not sleep well. It's normal to feel anxious and not overwhelmed. But, there's such a difference between what's normal versus what's common, right?
Yeah.
And yes, it is very common. It is very common for patients to have these symptoms, but that doesn't mean that it's normal. And so, or even if it is normal, if we say, yes, perimenopause, going through it is normal, but it doesn't mean that there's nothing we can do about it.
Yeah.
And so I 100% agree with you. Have a conversation with a physician, somebody you trust, somebody you can connect with. And everything is not a disorder. Everything is not a disease, but it's also not a patient's job to figure out what is a disease and what's not, or what is a disorder and what's not. And we're all going to have something as we get older. You're not broken, you're not faulty, as we age, I think every single human being is going to develop something. So
Yeah,
there's no shame, there's no embarrassment. I know so many patients feel like it's a failure when they have to take medication for
sure.
something.
Yeah,
There's work I do being like, this is not your fault. I mean, genetics,
yeah.
epigenetics, it is age. It is actually a normal part of aging that you're going to have some conditions that require treatment and medication.
Mhm.
And just having that conversation in kind of an open and understanding safe ways.
Yeah,
So important for women, no
for
matter how healthy they've been their whole life or how high functioning they are.
yeah, for
Yeah.
sure. Yeah, yeah. I think we would both leave to say that we want women to come have a conversation with us, either for mental health for me, Muna Psychiatry Group, or with Dr. Kumar.
Yeah,
Yeah. So
absolutely.
here
Absolutely.
we're here to help. Yeah, for sure. Thank you, Dr. Kumar, so much.
Yeah, thanks, Dr. Okeke. It was a good conversation. And I look forward to connecting with you more in the future.
Oh, yes. Thank you again so much for your time. I love this, and I look forward to doing this again on another topic.
All right. We'll see you later.
Bye.